Hello, and welcome to this Clinical Insight case discussion on the diagnosis of IPF. My name is Dr. Maryl Kreider from the University of Pennsylvania. I would like to thank my esteemed panel for joining us today. There are several things to consider when evaluating a patient for suspected IPF. It is important to obtain a thorough patient history, including environmental exposures. To begin, this is a 49-year-old patient. This is a 49-year-old truck driver for a concrete firm. He has a 50-pack year smoking history. This past spring, he noted some worsening in a cough and some new mild to moderate dyspnea on exertion. He was tried on inhalers without relief. He does live in an old house with a basement that occasionally floods. He denies exposure to any hot tubs, pets, or unusual travel or hobbies. And he had a father and uncle who died of lung troubles, but he was unable to tell us any more about what that meant. And Kevin, if you could take us through the CT a little bit, that would be great.
So we're looking at the first image. It appears to be in the upper third of the chest. The tracheal shadow looks a little dilated. Most of the findings are localized to the right lung, where we see a pattern of subpleural sort of cystic change. I think I would call it honeycomb change. You don't often see well-defined bronchi in the upper lobes, so it's hard to know if there's traction bronchiectasis, although I suspect there is. There's some thickening of the interlobar septa, and there's no ground glass change. The disease is asymmetric, so the left side shows similar findings, although quite much milder in appearance. As we move down, again, a striking feature is on these images, you see no evidence of much in the way of honeycombing, but there is evidence of traction bronchiectasis, particularly in the right posterior basilar segment. There's a very nice demonstration of that, actually right medial basilar segment. Not much in a way, perhaps very mild ground glass change or mosaic change, and there's clear thickening of the interlobar septa throughout. And then in the lower lobe, again, we have a localized area of what looks like honeycomb change in a subpleural region in the right posterior basilar segment. There's some subtle changes in the subpleural area on the left, which appear quite mild and not clear-cut honeycombing, at least not yet. And then the striking feature of areas both within the area of honeycombing of traction bronchiectasis, but also see an area of traction in the anterior basilar segment of the right lower lobe as well. So it's an interesting finding. It suggests that perhaps there's some subtle fibrotic disease dilating these bronchial shadows that are not entirely evident on CT scan. It certainly suggests that. So this is an unusual pattern.
Yeah, I worry, as you mentioned as well, that there just seems like there might be a little bit of ground glass or mosaic attenuation. There's areas of the lung field that look darker, and areas a little bit lighter, and it's always hard to figure out, is that air trapping that's making it darker, which might suggest some of a small airways component, or is the more ground glass area the abnormality? And I just get the feeling there's something going on in the background there that's above and beyond the reticulation, the traction bronchiectasis, the honeycombing that you mentioned.
No, I agree. And sometimes when you see these sort of isolated areas of traction bronchiectasis, that supports that idea that maybe there's some subtle fibrotic process going on that doesn't have pure honeycombing, but is producing some of the changes in the bronchial shadows that we're seeing. Yeah.
So with that somewhat unusual CT, he also got some PFTs.
Yeah, so if we look at the pulmonary mechanics, he initially has a restrictive physiology. His FVC is decreased at 48%. His FEV1-FVC ratio is not obstructive. His restriction is confirmed by a low total lung capacity. That's about 60% of predicted. The interesting finding for me on the mechanics is after a bronchodilator, he does have some bronchoreversibility. So it echoes what we know in clinical practice, that patients who have bronchoreversibility may not feel better on inhalers, just as patients that don't have bronchoreversibility on a PFT may actually have symptomatic benefit to bronchodilators. And then the other feature that he has is a decreased diffusion capacity for carbon monoxide, his being 36% of predicted. So overall, a pretty profound level of restriction, FVC 48%, very low DLCO at 36%, and a little bit surprised by the degree of bronchoreversibility.
So if you put together these PFTs and the prior CT, what kinds of diseases are on your list that might explain some of this?
Well, first of all, he has interstitial lung disease. We don't know the etiology yet. He has pulmonary function tests that suggest restriction, but also the degree of reversibility suggests some type of an obstructive overlapping problem as well. He's a smoker. He's a young man, so he has hyperactive airways. You wonder if there could be some asthma history in the family, but in this case, I would worry more about COPD, but also interstitial lung disease. And I think the question will be, what type of interstitial lung disease does this patient have?
Can you think of interstitial lung diseases that would explain both the CT and the PFTs? What do you make of small airways disease in people with interstitial changes? Do you have to invoke two different diseases, or is there one that might pull it together?
Well, his history is interesting. It raised a lot of suspicions. I believe there was a bird in the house at one point, or what was it? There was something in moldy basement. That's what
Basement
it was.
that floods.
Basement that floods.
Flooded, yeah. So that's it. Yeah. There was no bird in the house, but the moldy basement certainly, raises questions about possible hypersensitivity pneumonitis, along with the small airways findings on PFTs, and certainly his CT scan could support that diagnosis. I'm always concerned about occult autoimmunity because they produce lots of unusual appearances on CT scans, autoimmune-associated interstitial lung disease.
Especially in a young person.
Especially in a young person.
49 years old, male, funny CT scan. Clearly, big smoking history. So a lot of this could be the smoking, but I sense we don't want to rely on that smoking history. We need to dig deeper and not be complacent that this is all related to smoking. It certainly could be, but you got to look hard.
Well, there's recent data suggesting that there's a significant amount of interstitial lung disease in smokers, smoking-related interstitial lung disease. But the degree of honeycombing is quite impressive.
Yeah. It certainly would not be a pattern we would expect to see with RBI-LD alone, which is typically more fine interstitial changes with some ground glass, but not frank subpleural honeycombing. So I think, certainly there's a component of airway disease, perhaps related to cigarette smoking, that's important to consider. But there's another diffuse parenchymal lung disease that probably accounts for his more recent decline.
How much does his age influence what you think might be going on with him? He's 49.
To me, it means a lot. I really, as we look at the incidence and prevalence data for idiopathic pulmonary fibrosis, it's definitely more common in men than women, but it becomes much, much more common as people get older. So for me, as people are in this age range, under 50, I have a much broader differential diagnosis of the types of interstitial lung diseases, as opposed to if we were talking to him as an 83-year-old. Where my differential is still there, but my pretest probability of an 80-year-old having IPF is super high. Of a 49-year-old, it's low.
I would agree, and even if he had classic CT scan findings for UIP, I think that doesn't apply to someone in his age group. He's too young for me to rely on a CT scan to establish that diagnosis. I would much more inclined to pursue a biopsy, assuming secondary causes are excluded, even with classical CT scan findings.
I don't know. I think if his CT showed UIP, I don't think I'd find something different on the biopsy. But I'm just going to look harder for what's driving that. So to me, the pattern may not change so much. I don't think I'm going to find something drastically different on the biopsy.
Well,
but
HP.
HP would be the one example.
HP would be an important thing to find in a person his age group, given his occupational exposures. That because I think it's much more likely that that's going to be the driver of his lung disease than idiopathic causes. Than idiopathic lung.
What do you make of that story of other family members with lung trouble? Here's a younger man with an interstitial lung disease who has family members with lung trouble. And often we assume this is some other kind of disease, and perhaps COPD if the family members are smokers. But the question of familiar interstitial lung disease that could occur in different settings and with different kinds of interstitial lung disorders might be present here.
I worried about that as well when I saw that. Here's a young man, he has interstitial disease presenting very early. He's a smoker. So if you start thinking of gene and environment interactions, the familial cases often manifest earlier or manifest in people that are smokers. So I don't know what lung trouble means, but I had the same thing pop up on my radar. Boy, I wonder if this is a case of familial interstitial lung disease.
And what's striking in that population is the lung diseases can be variable. So you don't, within a family, you can have some patterns that are UIP, some patterns that are different types, COP or NSIP patterns. And so I think that's a very important point.
How about genetic testing?
I don't believe there's any role for genetic testing in the evaluation of lung disease in a person, if a person's asymptomatic. So I wouldn't do genetic testing in family members. Mm-hmm. In his case, I think the most important question is what's behind his disease first. What is his diagnosis first? Genetic testing is a tough problem because I don't think it's not quite ready for prime time as part of the routine evaluation of patients with lung disease. I think still it's a research tool. And institutions that do it seriously have genetic counseling facilities available to support patients with that. We don't do that routinely, and we don't encourage patients to have genetic testing outside of a research study. Now, obviously we're involved with lots of research studies, so I often do bring this up, genetic testing, but I don't think it plays a role in routine clinical care. We're not quite ready for that yet. Yeah.
So this gentleman did go on for surgical lung biopsy.
I agree. I would have considered a lung biopsy as well. He's young enough. If you're going to provide a patient at this age with a diagnosis that are going to last for the rest of their lives, you better know exactly where you are. And in the absence of comorbidities, why not consider this?
And he's got potential exposures, both occupational I think he's a concrete driver, this moldy basement or the basement that floods certainly makes me worry about chronic, mold exposures with which we.
And this funny family history.
And this funny family history. So I agree. I would have done a lung biopsy in this person as well.
This is an interesting biopsy because the features are not very specific for any particular disease, at least to my eye. So there's some diffuse nature of the interstitial changes, although you may see on the right side of the image some normal, or at least more normal interstitial areas that would suggest some degree of heterogeneity, as you would see in idiopathic pulmonary fibrosis or in the UIP pattern. But this is not, strikes me as a UIP pattern. There's some other areas also that might suggest fibroblastic foci, but on the top corner there's also a multinucleated giant cell, which also makes you suspect the possibility of environmental exposures and hypersensitivity pneumonitis. So this is not a very specific histology. It suggests an idiopathic fibrosing pneumonitis, and I think with the history, I think hypersensitivity pneumonitis is starting to be more consideration for me.
I agree, and I think this case really drives home that subset of cases that really benefit from multidisciplinary team discussion. We've got a lot of funny things in this guy's history that we can bring to the table and discuss with the radiologist. The radiologist can help us sort out, is this air trapping or ground glass? The pathologist can help us sort out, is this just an isolated granuloma that they sometimes see as bystanders, or is this really airway centric and part of the pathology? So this is one of those cases that's clearly not straightforward, easy, and it's these types of cases I think that benefit the most from having that team interaction of really figuring out what are the pertinent CT features, what means something on this biopsy, sort out all these funny histories that we're worried about that maybe aren't driving this pathologic process.
No, I agree. I think, and pathologists benefit by the interaction as well as the radiologists, because we all provide unique perspectives that I think enhances the certainty of pathologist who's evaluating a specimen like this. So I think I agree. I think this is a great case for a multidisciplinary approach, and it's one of the reasons why I think referral to a center that offers that multidisciplinary approach would be a valuable thing for a patient like this.
It emphasizes that concept that these disorders are, their diagnosis is a clinical radiographic pathologic diagnosis, that no single finding, no single test can actually help you with that diagnosis. You need all the above sometimes to come up with the appropriate answer.
Terrific. Well, I'd like to thank the panel for joining me today. This is an excellent case that will highlight the importance of the multidisciplinary team and at pushing for those funny edges on cases, the funny exposures, the funny family histories, to make us look a little more closely at the CT as we make our diagnoses. Thank you.